women, and there has been some reluctance among clinicians to give cefazolin even when it may be a safe agent for a subset of these women. And women with inadequate prenatal care also have been challenging in terms of both, they may miss the opportunity for the antenatal screening, but they also seem to miss the opportunity for IAP even when they present at labor. So if we go to the next slide, we have feasibility challenges in the US, but there are also feasibility challenges, I know, for IAP in many LMIC settings, and Ziad mentioned some of these earlier, and I do think there may be some more discussion of this also on that plenary on day 3, so I'm encouraging all of you not to skip out to the safari until ISSAD is over. But if we go to the next slide, in most LMIC settings, antenatal microbiologic screening is just not practical, and certainly not outside the context of a special study. And there is some potential for risk-based approach during labor, particularly in hospitals that are able to do that. But there may be barriers even in these instances. So we know it's a non-starter to do intravenous antibiotics for home births, but even many women who deliver in hospitals in a lot of settings present late in labor, and they may not have the opportunity to get these 4 hours of the antibiotic. And even if they are there, there can be challenges with having sufficient supply, with having enough qualified staff. And I've been one of the people, but I think there are many, including some in this room, that have tried to explore, could there be alternatives to IAP that would be practical for low and middle income countries. And one of my first global collaborations, I was very honored to work with Claire Cutland, and that was my first project with Shabir's group. I didn't know at that time they were going to become the Group B Strep powerhouse that they became, but we evaluated the efficacy of chlorhexidine vaginal washes given during labor in preventing Group B Strep infant disease. And there was some observational data out of Malawi at the time that motivated this trial that suggested it could be a very promising approach. But unfortunately, this trial, I think Claire and I liked to say that we confirmed that chlorhexidine was no better than water. It just didn't work. I also had the opportunity to be on one of the trial committees for a trial led by Dr. Ana Roca that was looking at single-dose azithromycin intrapartum to try to prevent a range of outcomes, including neonatal sepsis, and unfortunately we didn't find any evidence. It does show in observational data some potential, but now we're in IAP territory again, like we're combining IAP with this IM penicillin. People also have always been looking to giving antibiotics antenatally before labor, and could that work? And it just hasn't been shown to work, so unfortunately that's not a way out. So if we go to the next slide, implementation feasibility, the lesson I take is that it's going to be trickier for some groups, and it's going to be trickier in some settings. And implications for maternal Group B Strep vaccine, I think we all hope that vaccine will be more feasible than IAP for LMIC. We do have maternal vaccines in use in LMIC, and so that's a great head start. And I think now would really be the time to focus on demand generation and planning for implementation challenges. And as with IAP, it's my prediction that reaching preterm deliveries with a maternal vaccine may be the most challenging and probably requires some thought already. And then if you go to the next slide, I myself am not really an implementation expert, as many of you in the room are, but tomorrow and the next day we're going to have a lot of discussions on this topic, and so I think we're all going to learn together about planning for implementation with maternal vaccine. Next slide. So finally, it's important, even if you have a good intervention, or maybe especially if you have a good intervention, there are always going to be concerns and people who are worried that it may be doing more harm than good. And this has certainly been the case for IAP. And so we've spent quite a bit of energy in the US monitoring for potential unintended consequences of IAP. And the biggest threat to IAP would be the emergence of beta-lactam resistant Group B Strep. This would threaten not only the prevention strategy, but also treatment. So we again used our active surveillance to try to monitor for this, and I'm showing you here some work by my former colleague Mawako Kobayashi, again using the active surveillance data, and the x-axis here is year, and the y-axis is showing us the proportion of isolates that have reduced beta-lactam susceptibility. The green line that you see is the very rare proportion of strains that actually are at that non-susceptibility threshold. And then the blue line are strains that have some reduced susceptibility but haven't met the criteria of non-susceptibility. They do have changes in the penicillin binding proteins. So can you go back just quickly when, what worried us at the time, the reassuring thing is these are extremely low proportions, mostly below 0.4, 0.5% of strains. But what worried us at the time was this blue line that looked like it was creeping up. And it sounds from current looks at the data that this hasn't continued to creep up. But I think as an evolutionary biologist, we can never rest easy, and we know that bacteria are always evolving. So this has to be watched. Now you can go to the next slide. We also were worried in terms of IAP with the potential effect on other causes of early onset sepsis. And in particular, there are pathogens out there that are ampicillin resistant, for example, and those have raised specific concern. So to track this in the US, we set up a surveillance that was for all-cause early onset invasive sepsis. And I'm showing you here some data that is in the era of widespread IAP. The purple line at the top is showing you the invasive sepsis due to all pathogens. And the blue line is the Group B Strep sepsis. And the gold line is E. coli sepsis. And E. coli is our #2, and in some settings our #1 neonatal sepsis pathogen now in the US. There is a lot of ampicillin resistance, and so we were very worried about potentially causing increases in E. coli. And what you can see here is quite reassuring so far that there isn't a hint of changes in E. coli in this era of widespread IEP. And if you go to the next slide, we were further concerned because E. coli is really a big problem for preterm and very low birth weight infants, and it might be that looking at the overall trends is swamping out what might really be happening in this disproportionately affected group. So here I'm showing you on the left the preterm plot, and then on the right the very low birth weight plot. Again, the gold is E. coli and the blue is Group B Strep. You can see that E. coli dominates Group B Strep in these subsets, but it doesn't appear like we see a concerning trend in terms of increasing incidence rates. Next slide. Another set of concerns, and this was a newer kind of concern that has emerged as the understanding about the microbiome has also grown. And people have worried that there could be really lasting consequences of disruptions of the microbiome due to this IAP exposure at birth, which is right when babies start to establish their microbiome. And many outcomes of concern in this context have been hypothesized, including childhood weight gain, gaining too much weight, allergy concerns, and concerns about increased risk for certain kinds of infections. And I had the opportunity to collaborate on 2 independent studies that were evaluating the childhood weight gain outcome. And I do want to give a shout out to a couple of the co-authors from one of those studies are here at ISSAD, Karen Popolo and Sagari, and you should look for them. Sagari just gave a presentation earlier about, I think it was today already, about the microbiome. But both of our studies found a modest but statistically significant effect at 5 years of age. And in the California cohort, they were able to actually look out to kids who at 10 years of age. And interestingly, this small increased weight gain persisted at that age. But we don't really know what it means. The increase in weight was quite small, and so we still don't understand the implications directly for overweight and obesity. Next slide. So here, I just wanted to help us all anticipate unintended consequences of concern related to a maternal Group B Strep vaccine, because I think these are worth thinking about. A direct concern is always adverse effects, adverse reactions to the intervention. And with IAP, the blessing that we had there is that these were very familiar agents where the allergy and anaphylaxis risks had been well described, and we haven't really had any surprises on that front. But with a new vaccine, there's going to be an intensive engine focused on understanding the safety of the vaccine and the associated adverse events. And that started already with the phase 2 work and will continue with the phase 3 trial, but is going to extend well into the period post-licensure, and I think we'll hear some discussions about how we'll monitor that tomorrow. With IAP, we worried about the emergence of antibiotic-resistant Group B strep, and with maternal vaccine, we worry sometimes about vaccine escape strains, and for some of the pneumo people in the room, you know about the risk of capsular switching or other recombinant events that can happen and make a vaccine less effective, and we'll have to watch for this with Group B strep. For IAP, we worried, as I just mentioned, about a potential increase in other causes of neonatal sepsis once we bring down the Group B strep. And I think it is possible that an analogous concern could arise with a maternal Group B strep vaccine. I think this would mostly come up if the vaccine ends up being effective at reducing maternal and newborn colonization. And people might start to worry, is that leaving a vacuum for some other pathogen to come in, and maybe that will be a bad bug. IAP, I think the unique to IAP concern is really this microbiology of concern. They probably already are of concern, and that there may be many to consider. So this, again, as we think about where we are today, now is the time to start planning and designing these relevant evaluations. And I want to point out that these may extend beyond just Group B strep to other maternal and newborn concerns. Next slide. But I did want to touch on, there is some new territory that we vaccine, which is what would that mean for IAP and for countries that are using IAP. So if we go to the next slide, I personally think there's real potential for ongoing value of IAP, especially initially in the early time after a vaccine may become available. And this is because for unvaccinated women, IAP provides a safety net. It can be administered to women who refuse vaccine. It also, we have the risk-based strategy that can be applied to women who maybe didn't have prenatal care and would never have had the opportunity to be offered the vaccine. I think IAP may provide added value or a sense of added reassurance. We know that IAP is equally effective against all serotypes, and in the US, early onset disease does present with more diversity of serotypes than late onset disease. And some of us have spent 25 years hoping for